Hi, I'm Dr. Rajiv Raman. I'm a senior retina consultant at Sankara Nethralaya, Chennai. Today I'll be sharing with you an interesting study which we did on diabetic macular edema. There are two definitive treatments in diabetic macular edema, anti-VEGF and steroid. Enough evidence to support this. We also know that anti-VEGFs are the first line therapy for diabetic macular edema. We always believe, and there are enough evidence, that VEGF is an important mediator. It increases the vascular permeability, and in diabetic macular edema, it's nearly raised 2 to 3 times. We all know that not all proliferative retinopathy have diabetic macular edema. So we ventured out to find out what are these non-VEGF mediators, or what is the role VEGF plays in pathogenesis of diabetic macular edema. So we can measure these cytokines. We can measure it in the aqueous. People have tried using serum cytokines, the blood, but we don't want to pull the vitreous. So we thought of a novel way of collecting this vitreous in diabetic macular edema, collecting what is called as the reflux. So whenever you give your intravitreal injections, the amount which is injected, some amount of vitreous comes out, that's the reflux. So we thought, can we collect this vitreous and look into the cytokines? So we collected the vitreous reflux on the Schirmer strips, and Dr. Anglia standardized the method to estimate the protein. So we used a Bioplex multiplex assay, that's a commercially available kit, to find 27 of these cytokines. Now these cytokines were both angiogenic cytokines as well as inflammatory cytokines. And in our pilot study, we had 3 groups of patients. One group which was normal, they didn't have diabetic retinopathy, and these were essentially those who had macular hole. The second group had center involving diabetic macular edema who were undergoing injections. And the third group was proliferative diabetic retinopathy, where surgery was done and the vitreous was collected. So as expected, what was there in diabetic macular edema? VEGF levels were high. It was highest in proliferative diabetic retinopathy. It was about 1.05 fold in diabetic macular edema, much higher, nearly 2.5 times more in proliferative retinopathy. Very well known, very well proven before. But what was surprising was that it's not VEGF alone. There were a couple of other cytokines which were raised both in proliferative retinopathy and in DME. However, the one which was only raised in DME was the IL-1B. There were many of the cytokines which were common between proliferative diabetic retinopathy and diabetic macular edema. So what happens to this interleukin-1 beta? It's highest in diabetic macular edema. There was nearly about 1.5 fold change as compared to those who had no diabetic retinopathy, and in comparison with those who had no DR, again more than 50% of the cases it was more than 2-fold increase in IL-1B. So another cytokine which was raised in diabetic macular edema was IL-1RA, IL-1 receptor antagonist. It was nearly 57-fold more increase in cases with diabetic macular edema. And what was interesting, this ratio of IL-1RA to IL-1B seems to play a more important role. That's about 13 times more raised in diabetic macular edema as compared to proliferative retinopathy. It was interesting that in early stages of retinopathy, both are normal. Gradually, we see that both increases with the increasing severity of diabetic retinopathy, and at one stage, the protective effect of IL-1RA seems to get lost, and IL-1B predominates, causing the phenotype of diabetic macular edema. So as we had shown that IL-1B and IL-1RA in the vitreous probably plays an important role in diabetic macular edema, likewise Dr. Shobha Shivaprasad from Moorfields, very elegantly she has shown in a publication that these levels also seem to change in the blood too. So probably this can be a future serum biomarker. So what's the clinical implication of all these? This means that IL-1B and IL-1RA can probably act as a biomarker for diabetic macular edema and diabetic retinopathy. And in future, if we can standardize these techniques, we can do a more personalized treatment. People who have these inflammatory markers probably may do better with steroids, and those where the angiogenic mediators are more may do much better with anti-VEGFs. So probably IL-1B can also act as a therapeutic target. In fact, there are many diseases like rheumatoid arthritis, gout, and some autoimmunopathies where IL-1B blockers have been tried. This also suggests that these may have some role in the management of diabetic macular edema. There are many studies using aqueous, and some of them have actually used a vitreous aspirate to look into these cytokines. And one thing which is common, that in the vitreous probably IL-1B is important mediator, in the aqueous it is IL-6. So in summary, what we have known by this study, both angiogenic and inflammatory mediators are involved in DME. So there is VEGF, but we also have many of non-VEGF mediators. VEGF is still an important cytokine. It's important in diabetic macular edema as well as in proliferative diabetic retinopathy. But what this study came out with, that it's IL-1B, or more so the ratio of IL-1RA to IL-1B, which is more important in diabetic macular edema. So this is a step towards personalized care in diabetic macular edema. Thank you.